Welcome back to part 3 of this virtual mini conference, Disability Justice in Emergency Conditions. For those of you joining us after the fact on YouTube, where you're seeing each panel as a separate video, this is an event sponsored by Georgetown University's Disability Studies program with support from the Department of Philosophy, as well as Georgetown's Medical Humanities Initiative. We have ASL interpretation occurring live, as well as Zoom live captioning. Simply hit the More button inside of your Zoom app and then hit Show Subtitles to see the subtitling. 2 announcements I want to make for those listening. I'm very excited that the inaugural issue of the Journal of Philosophy of Disability, more than one speaker today is going to be in that journal. The inaugural issue comes out on November 18th. So mark your calendars and take a look at our website. Just type in Journal of Philosophy of Disability in Google and you'll find it immediately. It's going to be a really great inaugural issue. I also want to let people know that if you are interested in the sorts of conversations we're having today, and especially if you are an educator working really anywhere in higher education or in med schools, there is a book coming out called The Disability Bioethics Reader. It's coming out with Routledge. I had the great joy of editing this with Christine Wiesler, and that should be out this May. So keep that on your radar. It's the first introduction to the field of bioethics that centers research in critical disability studies and philosophy of disability, and also centers the lived experiences of disabled people. With that introductory material being completed, I am super excited to introduce our final panelists. As we have done earlier in this conference, I will introduce the panelists, they will speak, and then we will move through each of them and we will save the Q&A until the end. But please feel free to put your questions in the chat at any point. I'll go back and look at them and arrange them in a way that makes sense. Our first speaker for the final panel today is Ali Peabody Smith. Her talk is entitled Patient-Centered Communication, Intellectual Disability and COVID-19 Triage Care. Ali Peabody Smith is a PhD candidate in the Department of Philosophy at UCLA. Her research focuses on intellectual disability and moral philosophy. In particular, she's interested in the value of relationships with non-speaking intellectually disabled persons. Beginning in January, she will be a postdoctoral researcher with the Department of Neuroscience at UCLA's David Geffen School of Medicine. So happy to hand things off to soon-to-be Dr. Smith.
Thank you, Joel. And thank you again to all of my fellow presenters, our attendees, our interpreters, and of course, to the folks that put the conference together. I'm happy to be here today. Ali Peabody Smith, like Joel said, I am a white cis woman with short blonde hair, wearing a blue button-down shirt and unpictured in true Zoom fashion sweatpants on the bottom. I'll get started now. The normative ideal of patient-centered care has become fairly standard in clinical practice. One aspect of patient-centered care is patient-centered communication. This is communication intended to ensure patient understanding and participation in their care. Clinicians seek to communicate in ways comprehensible by the average person and in ways that take seriously each individual patient and their unique concerns. At the risk of overdetermination, in this talk, I'll discuss the myriad ways patient-centered communication falls short for intellectually disabled patients, particularly during crises like the COVID-19 pandemic. In the clinical care of intellectually disabled patients, particularly severely to profoundly disabled ones, clinicians are faced with a unique case where the patient lacks the communicative capabilities to self-advocate. Of course, there are many types of patients who cannot self-advocate. children, those with neurodegenerative or psychiatric diagnoses, those lacking a translator, and even those that have been systematically oppressed in a way that makes the case that they are unable to speak for themselves in a medical context. But non-speaking intellectually disabled patients are not like children who will become more immersed in language. They're not like those who have lost certain capacities that allow them to communicate effectively. They were never autonomous, independent communicators. And although they do comprise a vulnerable, oppressed group, the nature of their disability presents a particular challenge to clinicians striving to meet the ideals of patient-centered care. In a word, the typical directives of patient-centered communication do not lend to solving the unique issues at hand with non-speaking intellectually disabled patients. The norms of patient-centered care for people with disabilities do require effective communication and compliance with the Americans with Disability Act. But how are clinicians with little experience with non-speaking intellectually disabled patients to meet these requirements? The problems these clinicians face are twofold. First, clinicians typically work to discern a patient's agenda with open-ended questions. They avoid medicalese or interrupting the patient, and they engage in focused, active listening. But what does this look like when the nature of a patient's disability makes the case that they literally cannot speak? Typically, clinicians seek atypical means of communication, or they look to a translator, parent, or surrogate decision maker. I've argued elsewhere that those with severe to profound intellectual disabilities require more substantive face-to-face time with clinicians in order for these pairs to develop the communicative tools necessary. However, resource limitations often make it the case that clinicians are unable to devote the time necessary to these types of patients, and as such, healthcare outcomes can fall short of their potential. Beyond the looming practical problem of communicating effectively, a second structural issue affects the care that intellectually disabled patients receive. A 2020 study of over 25,000 clinicians conducted by Van Poynbroek, that's VanPuynbrouk, and all, assessed the explicit and implicit attitudes of providers towards disabled patients. Provider attitudes contribute to healthcare access and outcome disparity because of the way that attitudes shape clinical decision-making. Despite increased awareness of ableism, Van Poynbroek found that even though many clinicians expressed aversion to ableism, their implicit attitudes showed a favoring of non-disabled patients. Another 2021 survey of 700 US physicians conducted by Lisa Iuzzoni, that's IEZZONI, and her colleagues found that, and this is a quote, only 40.7% of physicians were very confident about their ability to provide the same quality of care to patients with disability. Just 56.5% strongly agreed that they welcomed patients with disabilities into their practices, and 18.1% strongly agreed that the healthcare system often treats these patients unfairly, end quote. Further, while these studies assess disability in all of its forms, intellectual disability is often a form of disability most affected by ableist attitudes. The conflation of the myriad forms of intellectual disability into the single cultural trope of the R word has had horrific consequences for intellectually disabled people, who are often perceived as bringing nothing to the table in terms of personality, interests, or inner life. In response to a paper on conceptualizing communicative limitations as central to characterizing profound intellectual disability, I once had a supervisor tell me that sounded like the people I was describing, quote, lacked what we typically call personality, end quote. This was a social and political philosopher, someone with a PhD and otherwise very well-formed progressive attitudes. What they lacked, and unfortunately what many people lack, is the interpersonal relationships with non-speaking intellectually disabled people. Anyone who has taken the time to get to know such a person knows the sentiment to be exceptionally poorly founded. And anyone who has spent much time among philosophers knows its reprehensible ubiquity. I'm not sure whether this is also true of clinical spheres, but I do think that the data emerging from the studies like the two I cited points to the prevalence of ableism that likely extends to non-speaking intellectual disabled patients in clinical spheres. One solution to the practical problem of communicating effectively, which could concurrently assuage concerns of implicit ableism, is the physical presence of a person who knows the intellectually disabled patient well during clinical encounters. The experiences of those close to these individuals suggest that plenty of non-language-based forms of communication do take place. Further, evidence suggests that the closer the relationship to that individual, the more successful an interlocutor will be in interpreting the disabled individual's non-speaking communicative acts. As I mentioned, clinicians typically lack the time to develop the relationships necessary for successful interpretation of these patients' desires and needs. This is not a mark against clinicians who must contend with resource limitations, particularly those that affect the amount of time they can spend with any individual patient. But it is abundantly clear that time spent with a non-speaking intellectually disabled individual can lead to the development of tools that might allow a person to discern atypical means of communication. I like to cite David Good's work in a rubella ward in the 1960s to illustrate how this can occur in a clinical setting. Children affected by the rubella epidemic of the 1960s were often born deaf, blind, and intellectually disabled. Sociologist David Good's work with these children highlights the ways in which unconventional forms of communication allow these children to come to communicate with their caretakers. When Good conducted his research, clinicians and care workers tended to diverge on many aspects of an intellectually disabled individual's perceived personality, characteristics, competencies, incompetencies, needs, and so on. After all, the clinicians working with patients like this in the 1960s typically only met with children once a year, diagnosing the children and moving on, and turnover rates were quite high among poorly paid and overworked direct care staff. Good's research orientation shifted when he began to focus his investigation on one particular child in the ward, a girl named Christina. He realized that focusing on individual children and individual relationships would create, quote, an opportunity to socially reconstruct that child in a fashion truer to their actual human qualities and capabilities, end quote. With Christina, Good endeavored to establish the sort of close interpersonal relationship that would allow for the pair to understand one another in a meaningful sense. Good also studied another intellectually disabled and deafblind child, Bianca, who remained at home with her family. In both cases, he observed unique communicative practices that developed within the fiber of particular relationships. He noted that for Christina and Bianca, communication was available via touch, proprioception, and most significantly via, quote, the engagement with their society that their senses and the structure of those societies permitted through the production and interpretation of indexical expressions, end quote. And the way that Good uses indexical expressions, it's nothing like myself and my analytic philosophy colleagues use the term. He means idiosyncratic communicative acts particular to the small groups of users who rely on the context and history of that relationship to communicate. Good and Christina, as well as Bianca and her parents, were able to communicate with one another in various ways. For example, Good would greet Christina by placing his hand on her face, and she would respond by gesturing to be picked up or by placing her right, less impaired ear on his mouth, indicating that she wanted him to sing to her. They were able to establish effective communication precisely because of the relationships that existed between the pairs. And then their relationships became the basis for additional successful acts of communication to occur. The flip side of this clinical example coin is, of course, that parents, caregivers, and friends to non-speaking intellectually disabled patients, pairs where relationships are pre-existing, likely have privileged perspectives on the desires and needs of these individuals. They have already spent the time necessary together to develop the kinds of relationships required to communicate effectively. The unique and challenging nature of communicating with non-speaking intellectually disabled patients has presented significant obstacles during the COVID-19 pandemic, particularly when some hospitals were limiting the ability of caregivers to be present with these patients. I suggest that denying non-speaking intellectually disabled patients an in-person advocate constitutes a particular form of healthcare injustice. Justice in healthcare should encompass things like equal access to resources, fair treatment of individual patients, a say in one's own treatment, or in some cases, the say of an advocate who can discern the patient's own or best interests. I know I had to miss the second panel, but I was able to glimpse through Eva and Donna's slides, and I think it seems that they powerfully highlighted that achieving just treatment is impossible for these patients when they are denied their much needed care partners. We know that during the early phases of the COVID-19 pandemic, the nature of triage care had devastating effects on disabled populations. Clinicians faced incredibly difficult decisions when allocating limited resources to overwhelming numbers of patients, each of whom presented life-threatening symptoms of a poorly understood virus. Much research has already been conducted regarding triage care and disability, albeit in non-pandemic circumstances. As highlighted by a 2020 report on the National Council on Disability, the use of quality or disability adjusted life years, QALYs for short, systematically devalues the lives of those with disabilities. QALYs are a commonly used economic metric in healthcare, and apologies to those of you that already know this. They're meant to compare the relative cost effectiveness of different potential healthcare interventions. They are used by healthcare decision makers and payers, like insurance companies, or to provide guidelines in triage settings. But the way that QALYs are calculated have a lot of problems. The questionnaires used are overly simplistic, failing to capture the manners in which some systems may cross domains, the symptoms which matter more or less to particular patients, or the impact medications or assistive technologies might have on mitigating symptoms. There are issues with nuance. They can make disabilities look similar when they are not, in fact, similar at all. There are issues with use. The same survey results can be used for different purposes, and the same survey can have remarkably different outcomes. One way of calculating QALYs involves asking members of the general population time trade-off questions like, how many years of living with a particular disability would you trade for a shorter number of years spent in perfect health? For example, a survey might yield that those surveyed would trade on average 20 years of blindness for 17 years of perfect health. We'd then divide 17 by 20, get our health utility score of 0.85, and that could then be used to calculate the QALY value of particular health interventions for the visually impaired, or to compare a particular health intervention for visually impaired patients with something for non-disabled people. But this means that non-disabled persons' biases and misconceptions of the quality of life of disabled people can have huge implications for the lives and treatment of disabled patients. Healthcare decision makers use the results of these types of surveys to assess the impact of disability on health, to choose what to pay for, and to determine how much, quote, worse it is to be in a disabled condition than it is to be in a non-disabled one, as if this were an empirically evaluable question. And Joe Stromando discussed this so-called comparative badness of disability towards the end of his talk. He argued that the epistemic opacity makes it the case that we can't make judgments about these sorts of comparisons, at least not in any meaningful sense. We already know that much of the population, providers included, have implicitly ableist attitudes that can affect healthcare decision-making and outcome. With QALYs, disabled patients unsurprisingly receive the short end of the stick yet again. Healthcare interventions for disabled patients have a lower comparable QALY value and are thus typically deemed not to be cost-effective. During the pandemic, with lives on the line, this is unacceptable. Compounding this issue, those who cannot speak for themselves or who lack an in-person advocate receive even lower prioritization in triage care. Whereas, at least in some forms of surveying that healthcare decision makers use, disabled populations have a voice. In the case of severely to profoundly intellectually disabled patients, these patients literally cannot speak for themselves. As such, an already vulnerable population becomes further disadvantaged. Dr. Wendy Ross, the director of the Center for Autism and Neurodiversity at Jefferson Health in Philadelphia, writes of the terrible toll the COVID-19 pandemic had on intellectually disabled patients. These patients are 6 times more likely than non-intellectually disabled patients to die from COVID-19. Early in the pandemic, Alabama's guidelines, which fortunately have since been rescinded, allowed doctors to deny ventilator access to patients with intellectual disabilities, largely based upon the low numerical quality outcome of ventilator use for this category of patient. Dr. Ross suggests that although healthcare workers needed to limit visits in order to reduce the spread of COVID-19, patients with intellectual disabilities need someone there with them in order to communicate effectively or at all. Beyond this, I suggest that both the guidelines of patient-centered care and the Americans with Disabilities Act require that an in-person advocate be present, regardless of circumstance, for non-speaking intellectually disabled patients. The metrics that healthcare payers and providers rely upon consistently and systematically tell us that the lives of intellectually disabled patients are less worth saving than those of non-disabled ones. Because most clinicians lack the time, impetus, or resources necessary to work closely with non-speaking intellectually disabled patients in the way that Good was able to, particularly in triage settings, we must protect this already vulnerable patient population by insisting on their right to have an advocate present. This is the best way to mitigate potential concerns of implicit ableism and their very real and often deadly practical effects. An in-person advocate serves both as a means to communicate, a translator of sorts, as a protection against ableist practices, and as an advocate in life or death scenarios in which healthcare provider attitudes and systemically ableist practices might lead to horrific outcomes. If we have learned anything about this patient population from triage practices in the pandemic, it is just that this relatively simple request might lead to more just healthcare, improved access, and fewer deaths. Insisting on the necessity of an in-person advocate for intellectually disabled patients, regardless of scenario, will help meet the goals of patient-centered communication and healthcare justice more broadly. Thank you so much.
Thank you for that fantastic talk, Ali. We are going to, as a reminder, we're going to save questions for the end of this panel as a whole. And we're going to move now to our next speaker, which is Dr. Johnathan Flowers. The title of his talk is Disability Justice and Emergency Response Beyond Accommodations. Dr. Flowers is a professorial lecturer in the Department of Philosophy and Religion at American University. His research focuses on the affective organization of experience. In particular, he's interested in the affective constitution of experience through identity and through disability as the ground for social and political transactions with the world. We are so happy to have you here, Dr. Flowers. The floor is all yours.
Thank you, Dr. Reynolds, and I'm quite happy to be presenting here. So without further ado, I will begin. So this work builds upon my previous, the thrust of this talk builds upon my forthcoming work, COVID-19 and the Disinheritance of an Ableist World, which presents COVID-19 as extending the ways that a world organized around ableism disinherits disabled persons. Here, I want to build on the central claims of that piece and extend them into the contexts of emergencies broadly construed. To this end, emergencies and emergency responses are part of a world that cannot be inherited by disabled persons, insofar as an emergency is an interruption to the built or culturally organized environment that sustains the functionings of bodies for which the environment has been prepared prior to their arrival. As the impact of an emergency is determined through its effects on the environment, any understanding of emergency that does not proceed from disabled bodies is fundamentally unjust because it fails to respond how emergencies are had for disabled people in their transactions with the world. This again results in the failures of emergency response to include the needs of disabled people as indicated by both the United Nations Office of the High Commissioner for Human Rights report on the rights of persons with disabilities in the context of climate change, and the Federal Emergency Management Agency's post 9/11 guidance for safe rooms and disaster response. Drawing on Ahmed, previously I have argued that ableism structures a world that cannot be inherited by disabled bodies. On this view, to arrive in the world disabled is to arrive already positioned as wrong through the ways in which the body itself is out of place or not at home, or unlike other bodies whose repeated activities have resulted in a history that organizes the world in its image. In a world organized around ability, to be born disabled is to inherit an orientation or a proximity towards the world that, as Ahmed notes, points to a past that is behind, that is prior to our arrival, and that thus structures the kinds of actions we can take in the world. In the case of disability, this past is best embodied by the four conceptions of disability articulated by Shelley Tremaine in Foucault and feminist philosophy of disability. The first model, disability as an intrinsic characteristic of an individual that results in discrimination against them. The second model, disability as the form of the discrimination imposed upon individuals with characteristics that mark them as disabled. The third model, which is a hybrid of two conceptions of disability previously mentioned. And the fourth model, what is typically identified as the medical model of disability, but which is interchangeably referred to as the conventional or medicalized model. And here we might also add the SSDI model to this list as well. So the various models of disability therefore form a past that precedes the disabled body into the world and serves to orient the disabled body upon arrival. Put simply, these models of disability organize ability and disability as orientations through the ways that they prepare the world for some bodies and not others. For Ahmed, orientations reveal the ways that some objects are placed in reach. They reveal the ways that lives are directed through the demand that we take up the inheritance that awaits us on arrival into the world. They also determine the ways that the disabled body is made visible or legible in the world. In the context of a world where the medicalized model of disability precedes the disabled body into the world as a history of ability and normalcy, the requirement that we inherit the line presupposed by ability is implicit in a moral imperative to fix or repair the disabled body. That is, for Ahmed, and I quote, "For a life to count as a good life, it must return the debt of its life by taking on the direction promised as a social good, which means imagining one's futurity in terms of reaching certain points along a life course. Such points accumulate, creating the impression of a straight line." And this is a line that is interrupted by disabled embodiment as organized by the ways that the various models of disability supply their conceptions of disability. Embodied in IEP and other institutional structures designed to make accessible a world organized around ability for disabled bodies, this past follows the disabled body through the world and runs ahead the disabled body through the ways in which it makes the disabled body legible in the world. Following Ahmed, this legibility is out of line with the presumed direction of normal bodies, and it is a legibility that has far-reaching effects in the world. For example, as Stramondo notes in his 2021 article, Triage Choices, Disability, Triage, and Equity Amidst a Global Pandemic, many of the early triage protocols during the COVID-19 pandemic made determinations for triaging disabled persons on the basis of the quality of their lives as predicted by the ways in which their medicalized path took them off the straight line of a good life as predicted by ability. As Stramondo states, quote, "The reason why such a person would be denied life-saving care via triage is because a third-party judge, like a physician or policymaker, does not believe that their life has enough quality to be worth saving in comparison with that of non-disabled others. That is, because the disabled body will be unable to meet the points that constitute a good life or adopt a line that projects a good life for disabled people in comparison to non-disabled people, they are deemed of less value in triage as a response to emergency situations." So as an orientation, ability is a way of inhabiting a world as familiar, as sharing a familial likeness or resemblance to the world. Insofar as a space is familiar, we can say that the space has been prepared for the body that enters it, that the body inherits a likeness to the space such that it becomes familiar, or more concretely, the space assumes in advance some starting points and not others, and is organized around those points. Insofar as ability is a way of being at home in a space, it is also an orientation that we inherit upon arrival. Thus, ability is a starting point from which the world unfolds and which serves to put some objects in reach through the ways that it orients bodies in space. On this view, ability becomes a question of what is in reach. Here, reach should not simply be understood as physical, but in terms of what cultural objects, life outcomes, and ways of being in the world are made available for disabled bodies. And among these cultural objects, we might count emergencies and emergency responses. So to make this clear, I would like to first turn to the FEMA definition for disabled people. First, FEMA defines special needs populations as populations, quote, whose members may have additional needs before, during, and after an incident in functional areas, end quote. This category includes children's, diverse cultures, language challenges, the elderly, and the disability community. While the inclusion of children is notable here, likely due to their dependence upon parents and caregivers, we might also note that special needs populations are those populations which cannot inherit the resources of traditional emergency responses due to the ways in which they are not at home in a world disrupted by an emergency situation. To be clear, while all bodies are disrupted or rendered homeless in an emergency situation, disabled bodies that were themselves not at home prior to the disruption of the world organized around ability. This is worth considering as the FEMA definition of access and functional needs parallels the definitions of special needs populations almost to the word. So put simply, in the context of emergency response, disabled populations are misfits prior to, during, and after an emergency, as defined by Rosemary Garland Thompson. In the context of emergency response, a special needs population, as defined by FEMA, is a population for whom existing emergency response procedures will not sustain the shape and function of the body within an emergency. This then is continuous with a world organized around ability, a world in which disabled bodies are already misfits, and a world that is disrupted during an emergency. This point bears specific relevance as, according to FEMA, this is a world that must be made accessible prior to an emergency. So insofar as Garland Thompson states, and I quote, "The built and arranged space through which we navigate our lives tends to offer fits to majority bodies," end quote, "and disabled bodies are themselves misfits in the world, it stands to reason that the ways in which disabled bodies have an emergency, or the ways in which emergencies unfold from disabled bodies as a starting point, is fundamentally different from the ways in which it unfolds for able-bodied subjects. To this end, disabled bodies experience emergencies in ways not accounted for and often prior to the declaration of an emergency by an institution or a world organized around ability." So here we need to re-understand emergencies. Again, FEMA defines an emergency as, quote, "any incident, whether natural, technological, or human cause that requires responsive actions to protect life or property," end quote. And a disaster is defined as, I quote, "an occurrence of a natural catastrophe, technological accident, or human caused event that has resulted in severe property damage, deaths, and or multiple injuries," end quote. Putting aside responsive action, FEMA's definition elides some assumptions about what a disaster or emergency constitute. Here, I would like to rethink property as supplied in the definition as not simply physical objects that one acquires through means of capitalism or other economic systems, but extending to include the built environment. As described by Mark Johnson, the built environment in the mode of architectural structures offers human subjects a way of situating and orienting themselves within a world. Insofar as the built world is also an extension of the culture world, the built world also supplies the ways in which we make meaning out of our world. Combining this understanding with FEMA's definition, the threat of an emergency isn't simply to property as defined by objects of acquisition, but property as the broad organization of the world through the built structures of the world. Reframed in this way, I argue that an emergency's threat only becomes apparent when it threatens the world that sustains and extends the non-disabled body due to its organization around the non-disabled body as the point from which this world unfolds. Put another way, an emergency becomes experienced, recognized, and declared as such when the incident disrupts the ways in which majority non-disabled bodies are at home in a space, or when the space fails to extend the actions of majority bodies. Moreover, the organization of the kinds of emergencies experienced are also structured by whose environment is disrupted and in which way. A pat example of this is the ways in which the opioid epidemic and the war on drugs are both framed as different kinds of emergencies requiring different kinds of responses based on which bodies are affected by the emergency. An epidemic in this context requires a massive public health response, while a war on drugs mobilizes a military-industrial complex against a threatening other. To this end, how an emergency for disabled bodies occurs is through the dominant paradigm of accommodation, at least institutionally understood. That is, like the other ways disabled bodies are included or accommodated in spaces that proceed from non-disabled bodies, spaces like educational institutions, workplaces, and other culturally organized locations, emergencies as an institutional structure are only understood as affecting disabled persons through the model of accommodation, or what FEMA describes as specialized procedures, which are activated only when the disabled body is made legible during an emergency. Put simply, by virtue of the unique way in which they are oriented towards the world, disabled people will not be served by default institutional responses to an emergency, and thus require emergency response itself to be made accessible. So this point is valuable. For something to be made accessible, typically a request for accommodations must be issued, which restructures the orientation of the disabled person in their relation to the institution. Insofar as orientations emerge from a history that precede the disabled body into space, a request from accommodations is simultaneously a request by those that organize the space to provide, or that the disabled person provide an account of their orientation towards the world, or why the organization of a space, including those established by emergency response, must be altered. Once more, FEMA is helpful insofar as it defines accessibility as the suitability, as quote, the suitability or adaptability of programs, services, activities, goods, facilities, privileges, advantages, or accommodations provided by a public or private, for-profit or non-for-profit entity, or any entity to which it contracts all members of the population, including individuals with disabilities, end quote. In other words, it is only on arrival into a space defined by emergency response that the disabled person can determine the accessibility of the response and thereby request accommodations to expand the space created for and by emergency response. Or as indicated by FEMA's guidance, it is incumbent upon the disabled person to plan ahead for an emergency situation such that they can accommodate themselves to a structure that does not proceed from their embodied experience. Put another way, disabled people must anticipate the ways in which a disruption to a world in which they are not at home will further disrupt the ways in which they are not at home, such that they can accommodate themselves to a response organized by people who are at home in that world. Or they must determine the accessibility of an emergency response on site during the disruption caused by an emergency. And even this is limited, as indicated by Marcy Roth, director of FEMA's Office of Disability Integration and Coordination, when asked about the provision of ASL interpreters in the wake of Hurricane Sandy. And I quote, "We are committed to providing access to effective communication. With the large number of disaster recovery centers open at once, it will be virtually impossible to provide enough interpreters from the moment they opened to the moment they closed each and every day," end quote. Understood differently, by virtue of the organization of emergencies and emergency response around the assumption of an able-bodied subject, or the assumption of the able body as the point from which an emergency unfolds, disabled victims of emergencies cannot be the inheritors of even our national emergency response due to the ways in which an emergency unfolds from the normative body. Instead, disabled victims of emergencies and disasters must rely upon the provision of support structures by the very institutional structures not organized around their experiences in order to survive the disruption of a world they themselves were only contingent members of. This, I charge, is grounded in the ways that FEMA and other emergency response organizations understand an emergency as primarily affecting those bodies that fit into the environment as organized. Emergency response is primarily organized around attending to the needs of majority forms of embodiment. Put another way, an emergency only becomes an emergency when it is experienced as a disruption in the environment commonly occupied by majority embodiments. Insofar as FEMA defines an emergency as any event, whether natural or technological, that requires responsive action to protect life or liberty, or life or property, and further defines a response as, I quote, activities that address the short-term direct effects of an incident. Response includes immediate actions to save lives, protect property, and meet basic human needs. I charge that both an emergency and the responses to it rely on an understanding of emergency as primarily through the able body. Insofar as this is the case, what we might understand as basic human needs, the ways in which an emergency disrupts the necessary accommodations that enable disabled bodies, or what Garland Thompson calls misfits, to be supported by the built environment, will not be adequately attended to in declarations of emergency. Owing to the unique ways in which the world unfolds for disabled persons, it is more likely that we will be impacted by an emergency or disaster prior to its recognition as such by an emergency response institution organized around the able body. This experience of an emergency as temporally preceding its declaration or even its recognition by institutional structures organized around the able body is but one way an emergency is experienced differently when the disabled body is taken as a starting point. To this end, I argue that the disabled experience of a disaster does not occur chronologically or linearly in a neat progression as might be assumed by a normative body. Rather, an emergency is experienced through crip time as defined by Allison Kafer. So insofar as crip time, quote, requires reimagining our notions of what can and should happen in time, end quote, a temporal experience of an emergency is not bound by when an emergency is declared, but the moment the emergency is experienced as such by a disabled body. This then reframes the pace or onset of a sudden onset disaster or slow moving event, not by virtue of when, say, a tornado touches down or when the flood waters rise to such a level as to warrant concern about the levee, but when the necessary services needed to maintain the lives of disabled people are disrupted. For example, in the context of evacuation from the path of a disaster or an emergency, it is to recognize that how long a disabled person takes to evacuate is relative to the ways that they are in the world through their disability. As one modality of disabled experience, accounting for crip time in disaster planning and mitigation, when taken up as the responsibility of institutions, can ensure the survival of people with disabilities through reframing how and when an emergency occurs. That said, despite the potential advantages of reframing a disaster and emergency response through crip time, this is but one more mode of accommodating disability. True disability justice can only be found through the full inclusion of the disability community in disaster planning. Doing so, as argued by the United Nations in the context of climate change, one of the largest emergencies facing humanity, not only remedies the epistemic and other justices visited upon disabled people during emergency situations, it also restores to us the agency that is so often denied in a world organized around ability. Thank you.
Thank you so much for that fantastic talk, Dr. Flowers. As I assume is true of everybody else, so many questions are arising in my mind and others about your talk and Allie's as well. We're going to jump into the next two talks and then we're going to have time for questions. I would like to remind those here today that you can drop your question for any of the speakers or all of the speakers at any time in the chat. And also for those watching on YouTube in perpetuity, I guess, I hope it's all right to speak on behalf of all of our speakers and say, please, shoot us an email, send us a message if you have a question, if you'd like to talk further about these things. This is our life, is to have the privilege and opportunity to think about these things deeply and try and make the world a better place. And I'm sure we'd love to hear from you if you have questions, comments, concerns, etc. I'm now going to move us to our next speaker, which is Dr. April Dowretz. The title of her talk is Justice in the Pandemic: Can Healthcare Catch Up? Dr. Dowretz is an associate professor of pediatrics in neonatology at Emory University, at the School of Medicine at Emory University. Dr. Dowretz is also a senior fellow at the Center for Ethics. She has an MD from the University of Pittsburgh, a master's of public health from Yale, and a master's in bioethics from Emory. She is the chairperson of the Georgia American Academy of Pediatrics Committee on Bioethics. Dr. Dowretz is also the past chair of the Disability Ethics Affinity Group of the American Society for Bioethics and Humanities, the ASBH. There's so many terms and acronyms. I'm trying to slow down. My apologies. She serves as the education chair of 2 bioethics committees at Grady Memorial Hospital and at Emory University Hospital Midtown, where I think I got my tonsillectomy. Terrible experience, not because of the doctors, but tonsillectomies are just terrible. Dr. Dowretz's scholarly work involves disability ethics and decision-making about life support in preterm infants. And the floor is now yours, Dr. Dowretz.
Okay, I'm just going to put my slides up. Can you see my slides? Because I can't. Can you see my
I
slides?
think we can only see part of the screen. If you hit full presentation mode, that may help.
I don't see full presentation mode.
On the bottom right-hand
Oh,
corner.
I'm sorry. Yeah, okay. Is that better?
Perfect.
Okay. Great. So I want to thank you, Joel, and the Georgetown's Disability Studies Program, my co-presenters, and the attendees, for putting this together and for being here. I'm a bioethicist and practicing neonatologist, as Joel said, I am a white cis woman with long, slightly wavy gray hair, with my living room window in the background. And lately I found myself talking on this subject a lot. What I'm hoping you'll take away today is an understanding of the ethical issues of crisis standards of care, or CSCs, especially regarding disability justice. I'll discuss the concept of crisis standards of care, and then I'll briefly review how ableism creates inequities in healthcare. These inequities must be
April,
addressed.
I'm sorry to interrupt you, but right now we can only see half of your screen.
Okay.
As opposed to all of the screen. I'm not sure
Is
why.
that better?
Yes. Can someone else confirm? Can you drop in the chat that you can see the whole thing? All right, and now we're good. Sorry for the interruption. Thank you so much.
Thank you for interrupting. So as I was saying, I will discuss the concepts of crisis standards of care, or CSCs, especially regarding disability justice. And then I'll briefly review how ableism creates inequities in healthcare. And thank you to some of my co-presenters like Desiree Valentine and Joe Stramondo for doing a more complete job than I planned to do, and setting it up. I will examine some of the bioethical justifications that we have to consider in developing crisis standards of care. And finally, I will describe the Pittsburgh framework, a CSC that pays attention to ableism, racism, and classism, and was developed in part by Doug White, a bioethicist and critical care physician at the University of Pittsburgh, and with whom I had no association before this talk. So this slide shows a row of critically ill patients, some of whom have ventilators attached, and a worker, all in a COVID unit, intensive care unit. Because of COVID-19, we've had to face possible shortages of critical resources. Crisis standards of care are what happens when there are no ventilators or not enough beds or not enough nurses. They help triage teams figure out to whom to give the sparse resources. At times, hospitals have confronted these shortages without equitable CSCs to fall back on. Instead, healthcare professionals, with their own biases, had to make decisions about who got resources at the bedside of their patients. Since the early pandemic, hundreds of hospitals and states have developed such standards for the COVID-19 pandemic for the potential situation when we need them. Not all of them are ethically justifiable. I will focus on the ethical concerns that challenge the development of equitable CSCs. This slide shows the back of a woman who uses a wheelchair, and she's currently sitting in a wheelchair that's facing a long, tall series of steps. She has her arms outstretched as if to say, what am I supposed to do here? We all know that health disparities affect people with disabilities, people of color, and poor people. They do so even more in situations when CSCs come into play. If there is ever a time to worry about intersectionality, it is when you have to make a life or death decision about allocating limited resources. And the COVID-19 pandemic has disproportionately caused infection and death for each of these groups due to health inequities. Health inequities, which result from ableism, racism, and/or poverty, are systemic, avoidable, and unfair. Can you imagine, when it comes to triage, how life circumstances can disadvantage a patient? For example, due to health inequities, people with disabilities have a higher risk of heart disease and stroke. In the case of COVID-19 infection, heart disease and stroke are comorbidities. If a triage plan considers comorbidities during triage, then it is inherently ableist. That is, the triage is based on disability, not comorbidity, and therefore is unethical. The rest of this talk is about what to look for in a CSC to avoid health inequities. I find it helpful to split the ethical issues into negative and positive obligations. I'll start with the negative obligations. So we should not factor in lives saved. Not saving the greatest number of lives may seem counterintuitive, although the foundational principle of crisis standards of care guidelines is utilitarian and aims to benefit the greatest number of people. If we try to save the greatest number of lives outright, we will significantly disadvantage people with disabilities and with other systemic health inequities. A system that penalizes on the basis of comorbidities will undoubtedly and unfairly punish the populations that are already more vulnerable to those conditions and already at risk for a shorter lifespan. Second, we should not factor in categorical exclusions. For example, we do not want to categorically exclude all people with disabilities. Instead, each patient must have an individual assessment. We should not factor in long-term survival criteria. People who have less long-term survival due to health inequities because of race, class, age, or disability deserve to have a chance for triage to life-sustaining treatment. And we should not factor in medical care based on quality of life. And Joe Stromando talked about this eloquently. Healthcare professionals rate quality of life worse for people with disabilities than people with disabilities rate their own quality of life. If it was used, people with disabilities would have unfair disadvantage. We should not factor in required resources at baseline. And we should not reallocate personal property to others. It may be hard to believe, but early in the pandemic, a few CSCs recommended reallocating the personal ventilators that people brought to the hospital. People with personal medical equipment stayed away from hospitals for fear of losing their devices and instead increased their risk of dying. The Office for Civil Rights righted this wrong. The ethical issues that we should take into account are next. We should factor in hospital mortality due to COVID-19. We do not want to give scarce resources to people who are going to die before hospital discharge. However, there are some ethical concerns with how hospital mortality is determined. Many CSCs use one of two validated mortality scores: the sequential organ failure assessment, also called SOFA, or the modified SOFA. These scores take into account medical assessments that determine in-hospital mortality. However, they are biased against people with disabilities and others who experience health inequities. For example, a patient who does not communicate verbally will have higher SOFA scores that may have nothing to do with increased hospital mortality. People of color who have higher creatinines due to health disparities will have higher SOFA scores. One recommendation is to make individual modifications to these scores depending on underlying disability. Whether triage teams will actually make these modifications is uncertain and even doubtful, depending on the degree of disability justice training the triage teams receive. We should factor in short-term life expectancy also. For example, someone who has a 2-month survival for a non-COVID illness probably should not get limited resources, but someone who has 2 years to live should be included with everyone else. We should factor in area disadvantage indices, or ADIs, and I'll explain this in a few minutes. We should factor in reciprocity, meaning workers who put themselves at greater risk for the public good deserve to have priority, and the multiplier effect, meaning by saving a worker, more people can be saved, to prioritize critical workers. And we should factor in a non-discrimination clause. I've tried to put this in a form that is complete enough and clear enough that you can use it. I hope I've succeeded. Now, hospitals and states have developed a plethora of CSCs since the pandemic began. If you want to read the most important work in this area, read White and Lowe's 2021 paper. Their crisis standards of care recommendations, also known as the Pittsburgh Framework, attempt to promote racial, economic, and disability justice. Citizens groups, ethicists, and disaster medicine experts developed the Pittsburgh Framework, and a few states and many hospitals have adapted the Pittsburgh Framework for their CSCs. I hope as I explain the CSC, you see how nicely it fits with the ethical issues I've just described. The Pittsburgh framework is a point-based system. Too many points means too many problems. Total scores range from -1 to 8, and persons with the lowest score would be given the highest priority to receive limited resources. Those with the highest score, too many points means too many problems, are at risk for losing or not receiving limited resources. A triage committee, not individual healthcare professionals, make resource allocation decisions, and individuals or healthcare professionals can appeal the decision. The Pittsburgh framework divides the standards into two main ethical principles. One, promoting population health outcomes on this slide, and promoting justice and equity on the next slide. The criteria for promoting ethical principle number 1, population health outcomes, include using a validated severity of illness score, such as SOFA, and the presence of an end-stage medical condition or near-term prognosis. According to SOFA score, points assigned range from 1 for the most likely to survive to 4 for the least likely. The reason? Factor in hospital mortality. The second criterion for promoting population health outcomes is presence of end-stage medical condition. What if the patient is not likely to die from COVID, but has another illness with a life expectancy less than 1 year? That patient receives another 4 points, lowering their chance of receiving life-sustaining treatment. Note that this accounts for up to half of the range of the overall triage score. The reason? Factor in short-term survival. Promoting justice and equity is a unique feature of the Pittsburgh framework. The use of ADIs, area disadvantage indices, help to even out the health disparities due to racism, ableism, and classism. This slide shows a map of area disadvantage indices for Atlanta. There are areas of different shades of red and areas of different shades of blue. What's nice about using such a score is that one can access it from the web by entering the patient's address. The red areas represent the most disadvantaged block groups. The blue, the other end of the continuum, represents the least disadvantaged block groups. The areas on these maps, based on patient education, employment, housing quality, and poverty, have implications in terms of health inequities, with the poorer neighborhoods having worse health outcomes. To give advantages to people living with poverty, 1 point is subtracted if the patient's ADI is high. Frontline essential workers, not just healthcare workers, also are disadvantaged in the sense that they are at higher risk of infection with COVID-19. Whether they are hospital housekeepers or grocery store workers, the public relies on their work. 1 point is subtracted if the patient is an essential worker. The reason? Reciprocity. The next two criteria are tiebreakers. Let's say CSCs are in effect. 2 patients have the same score and only 1 ICU bed is available. Who gets the bed? The first tiebreaker goes to those who have had the least chance to live through life stages. The second tiebreaker is random selection. The Pittsburgh framework also developed procedures to provide justice. They propose involving diverse groups of people, including people with disabilities at all stages, and providing diversity and equity training to triage teams to warrant their fair implementation of guidelines. What happens if the patient or a healthcare professional disagrees with the triage decision? There are review processes. And importantly, the Pittsburgh framework recommends the transfer of patients from overrun hospitals, especially safety net hospitals, to those that have resources available. Though I think any method for choosing who gets scarce resources will have pluses and minuses, I hope you've had a chance to understand some of the ethical issues that have gone into the processes of making CSCs more equitable. Of course, not all CSCs take into account how they discriminate against people of color, people who live with poverty, and people with disabilities. For some CSCs, the Office for Civil Rights had to require changes to comply with the ADA and other anti-discrimination laws. But that doesn't mean that the CSCs corrected for social determinants of health, as the Pittsburgh framework tried to do. This slide shows an apple tree with 3 people under it. One is a tall girl up on a hill, standing on 1 block. The next is a girl in a wheelchair, sitting on 3 blocks on top of the hill. And the 4th is a boy at the bottom of the hill sitting on 4 blocks. It's a cartoon figure. Lest you think this is all worked out, let me leave you with one major controversy. The SOFA and modified SOFA scores often disadvantage people with disabilities and people of color, and they were not developed to predict COVID-19 and hospital mortality, and yet they are used for that purpose. And most CSCs do not borrow the Pittsburgh Protocol's Justice Guidelines. It's been a pleasure to be here today.
Thank you so much for that fantastic talk, Dr. Dowretz. I'm excited to introduce our final speaker of the day as part of our final panel. Let me put him up on screen. So we have Kevin Timpe, whose talk is entitled Disability, Disadvantage, and Pandemic Public Education. Dr. Timpe works in the philosophy department at Calvin University, where he currently holds the William H. Jellema, I hope I'm saying that correctly, Jellema chair. Most of his scholarship focuses on the philosophy of disability, virtue ethics, the metaphysics of free will, and philosophy of religion. He is also president of 22 Advocacy, a disability advocacy company that specializes in protecting disabled students in public education from all sorts of problems and threats that they seem to continually face from every corner. Thank you so much for being here, Dr. Timpe. The floor is all yours.
Fantastic. Am I successfully unmuted?
I believe so.
Okay, and can people see my slides and not just me?
According to my screen, that is also a yes.
Okay, I just wanted to make sure. As the last person going today, on behalf of everybody else participating, I want to share the gratitude that has already been expressed to Joel for putting this event together, for the folks at Georgetown, for our interpreters for all day. This has been a fantastic event, and I am grateful to be a participant. I think it's probably pretty obvious to most of us that the pandemic has been bad. But as the previous speakers for most of the day have made clear, it hasn't been equally bad for everyone. One of the ways it has been bad is that it's taken pre-existing social inequalities and magnified them. Prior to the pandemic, there are inequalities in economic security, access to quality healthcare, differences in educational opportunities, not to mention the inequalities forced on some people given their identities, structural racism, sexism, transphobia, ableism, xenophobia, all sorts. And a lot of these other conditions have been highlighted by some of the other talks and subject to criticism here today. One of the important effects of the pandemic is in terms of, as Carol Hay puts it, exacerbating social problems that have always been there, making them such that even the socially privileged can no longer avoid them, and of course, making them even worse for those who have been suffering their brunt all along. Many of these groups that have already been disadvantaged by social inequalities are among those who have been hit the hardest by the pandemic. This next slide is just a graph taken from one of the recent papers on updated estimates of COVID-related deaths by disability status from a paper published this past year by the UK Office for National Statistics. There's a graph where it breaks down by both male and female and indicates what the increased risk that people are at on the basis of disability versus not being disabled. And there are females who are more disabled have 3 times the rate of death than the general public that contracts COVID. So these are the kinds of increased disadvantages that a number of folks have talked about here today. And I think all of those are important, and actually many of those are going to intersect with some of the issues that I want to talk about. But in the rest of the paper here, I want to talk in particular about a different kind of disproportionate impacts, namely special education. I actually think that there are problems with the phrase special education, but it is the phrase that is enshrined in federal law. And so I'm going to use it instead of terms that I think are more appropriate given that nature. So in particular, I want to look at how special education for disabled students in public schools has had increased impact. And of course, every student over the past year has been impacted by COVID and the pandemic. But as we've seen, and as the quotation from Carol Hay indicates, it has not been equal in any sort of way. So even prior to the pandemic, for those that are familiar, there are ways in which disabled students in public schools are especially disadvantaged. And it needs to be put this way in terms of disabled students in public schools, because there is no federal law that guarantees that private schools have to take disabled students. And so one way that disabled students are disadvantaged in private schools is they're often just kept out. But in terms of the general impact for disabled students by public education, there's going to be some of the intersections with the general healthcare access. These are going to intersect with some of the other categories like race and gender. And so in order to get special education services, you have to qualify under a number of different diagnostic codes, but often receiving those diagnoses require certain kinds of healthcare access. There's just a general failure for schools to follow the Individuals with Disabilities Education Act, IDEA, as well as their state implementation. This is a lot of the kind of advocacy work that Joel mentioned that I do. Is just going into schools and trying to hold them up to that legal standards. There are various kinds of pressures caused by the failure to fund IDEA as originally promised. If I remember, it was supposed to be funded by the federal government at approximately 40% of the cost per student, and it is currently funded at slightly less than 20% of the cost to provide services for disabled students. And every year, the federal government puts out a report card of how well the various states and municipalities are doing. And in the most recent one, only 21 of the 50 states' educational services were found to meet the requirements and purposes of IDEA Part B. So even prior to the pandemic, we see that things are not going particularly well on this score. This suggests sometimes the language is used of disabled students falling into the cracks. I think that there's actually a way in which the way that we approach public education is often done to sort of push disabled students into the cracks to make them not satisfy or not get satisfactory education. A really interesting example of this was from the early 2000s. In 2004, the Texas Education Agency told its districts that it should aim to have only 8.5% of its students receiving special education services. They said this isn't a benchmark, but anytime a state agency puts out this kind of statistic, it's not surprising. It was used as a benchmark. And so for quite a long time, Texas was only finding about a third the rate of students qualifying for special education that other states were. And by the time they were done investigating, they had discovered 189,000 students who had been denied services during this period. So it's not as if the system works particularly well, even in the best of times. But of course, the pandemic is not the best of times. So there are additional pandemic-caused additional disadvantages for disabled students. Many of these came about in the earliest days of the move online, the failures of access and initial move to virtual education. This is related to some of the conversations earlier this afternoon about telemedicine. We have lack of accommodations in virtual platforms. So when education moved initially online, a lot of school districts just said, let's use the resources that we have. And a lot of the resources that they had did not have the capability to make accommodations in them. The inability to access school-based therapy services in the same way that telemedicine is often difficult and puts additional burden on nearby caregivers trying to help administer PT, OT, or speech services that are given in public education via Zoom is also puts additional resources or burdens on individuals. And so what you had is in the first 2 to 4 weeks after the move to go online, a lot of schools weren't sure how to administer education online. So they just gave enrichment activities rather than official instructional time. And so state departments of education suspended the number of in-person instructional days that needed to happen in order to accommodate the initial push. And at least here in Michigan, that took a number of weeks for it to happen. Schools were in conversation with the federal government about what they were supposed to do. There was, for instance, in New Jersey, there's a state law that prohibits special education services from being provided using distance learning tools. And so in New Jersey, they were trying to figure out how in the middle of the pandemic, they were supposed to serve some disabled students at all. You had students who were blind that couldn't receive up-to-date Braille materials. Early on, Zoom was not particularly good for captioning, or some of the online teleconferencing was not particularly good for captions. And so in a white paper from Mara Levinson at Harvard's Safra Center for Ethics, she talks about how many states and districts decided to level down to offer no educational services to anyone rather than violate the principles of equity as policymakers understood them. IDEA and state implementations of IDEA are supposed to sort of elevate what is received by disabled students. But you had instead this push initially to offer fewer things, to try to figure out how to serve disabled students. And then that just became the default. By mid-March of 2020, an increasing number of public schools announced that they were canceling all government mandated meetings for special education students until schools reopened, which they admitted at the time might not be to the next academic year. Federal Department of Education Secretary at the time, Betsy DeVos, tried to counter this trend, at least in some of the things that she said. She wrote that if a local education agency closes its doors to slow or stop the spread of COVID and does not provide any educational services to the general student population, then that agency is not going to be required to provide services to students with disabilities during the same period. She came out a few days later and said, well, that's not a reason to not offer services at all, so you can get out of offering them for disabled students, but that's actually what happened. And so when I was working on this paper, I actually did a Freedom of Information Act request for our local public school district here, and I got about 1,000 pages of emails among school administrative officials about how they were planning for instruction online. The Grand Rapids Public Schools Legal Counsel wrote this on the slide: if a school chooses to use virtual instruction in place of in-person instruction for general education students during the closure, the school must ensure equal access for all students and FAPE, free appropriate public education for students with disabilities. Because DeVos's administration was clear, we're not going to suspend IDEA. But what districts realized was then the way to avoid having to live up to IDEA if they offered any educational services was not to offer educational services. The bottom of the screen is a screen capture from one of the emails I got from my local district, and it reads, no official instruction, ? No FAPE. When we shift from providing mere resources to instruction, we have to shift back to offering a free, appropriate public education. If we move to a virtual learning platform, we will be mandated to open every IEP. The district had almost 3,000 of them, every 504 plan, 188 of them, and non-public service plans. These are planned agreements between the public district and private schools, about 300 of them. And at least amend to identify what they will be receiving as our offer of FAPE, because FAPE needs to change when the environment changes. And she wrote, we will be crushed with compliance. And so then when they realized that if they did not offer any official instructional time, they did not have to offer free and appropriate public education, they decided not to offer anything. So this screen is a screen cap of one of the emails from Laura Lamore, the Executive Director of Special Education and Early Childhood Services from the Grand Rapids Public Schools, and it reads as follows. Okay, team, this is a game changer, smiley face. Please read and let's discuss. And she was forwarding the legal counsel judgment that the way to get out of having to provide disabled students with services was to not offer any sort of services whatsoever. And so they just offered optional instruction services rather than any. And this actually in Michigan ended the presentation or the offer of official instructional time for the entire school year. What this made difficult is sort of the initial switch, but then there were ongoing pandemic caused disadvantages beyond just, we're not going to give you modified curriculum, accessible materials. In addition to not having to follow the accessibility guidelines of IDEA, there's other kinds of disadvantages that came with this. One of the kinds of services that many disabled students receive are what are called ESY services, extended school year services. And these are educational opportunities over the course of the summer. And you have to have certain kind of metrics in terms of recent goals and progress in order to qualify for ESY services. But since schools weren't in person, they didn't have the data. And so far as I know, not a single student in Grand Rapids Public School District received ESY services last summer. Ideally, if services are not given appropriately, you're supposed to be able to get compensatory services. When those 189,000 Texan students were decided that they didn't get the services they were supposed to get, according to the way that the Texas Education Authority was doing things, only about, I think it was 9,000 students ever got compensatory services out of the 189,000. Is that right? I think that's the number. And even those that did get the services often only got them after significant work by the caregivers that had to push for them. There are staffing issues in public schools. So even when school resumed in person in the fall of 2020, there were staffing shortages related to physical therapists, occupational therapists, speech therapists. And so we found out, for instance, that one of our children was not given their guaranteed services for about 2 months because of a staff shortage. And so we filed a complaint with the Michigan Department of Education. And even though now most districts are back in person, and most districts these days are offering what they're legally required to offer, the disadvantage from all these services, all these experiences are going to linger in similar ways to how other kinds of experiences that people have talked about today. Public health threats require a structural response because there are public health structural issues. It's not enough for individuals to make the personal choices they think is best for them. This is why we're supposed to have public health policy, guidance, coordination. In similar ways, the ability of a country or state to provide special education requires a good structural response. And while public special education is governed by federal law, the pandemic has magnified how many of the previously existing structural inequalities that already exist in how the US approaches special education are magnified. The pandemic has been felt by all, but its harms have not been uniform. And those harms, as we have seen in talk after talk today, have fallen disproportionately on those who are often least situated in our culture to bear them. So this is part of a larger paper. If you're interested, it's a paper coming out in responses to a pandemic, philosophical and political reflections. You're welcome to email me and I'll share it. And again, thank you, Joel, for putting together this fantastic event that we have all participated in this afternoon.
Thank you so much, Kevin, for that fantastic talk. That was Schnurp. Yeah, no, this is not the right. Schnurp has decided it's time for him to eat dinner, and he's using all of the means at his disposal to procure such things. Very soon. I'm very excited to now have a open Q&A for this last fantastic panel. I'm sure people have so many questions, so please either raise your virtual hand, your real hand, or drop a question in the chat. As usual, I have questions and I will fill the space, and I don't want to do that. So please, someone else ask a question. All right, I see Joe. Yes, let me spotlight you. All right.
All right, I was trying to wait and give others a chance, because I feel like I've been asking a lot of questions too, Joel, but I figure I'll do it since everybody else seems to be quiet so far. So my question is for everybody really, but I think that it was a real explicit theme in Johnathan's paper and in Kevin's, this idea that there were sort of ableist structures that are disadvantaging to disabled people, generally speaking, in sort of all contexts because of the way things are, the environment that we have. But then they become more disadvantageous in the context of a crisis. And I'm really interested in that idea, and want to push back on it just a little bit. I certainly agree that that's the case in most situations that we've been talking about, but I started thinking about an experience I had a few years ago. Some of you might remember this. There was an Eastern APA, and in Georgia. I think it was Augusta, maybe. I don't remember. Somewhere in Georgia, or Savannah, I think. And there was a huge snowstorm that happened that year, and I was supposed to go to give. Actually, I think it was moderating. I don't think it was actually giving a talk, but I had my plane tickets bought. I had everything set up, and realized that there just was no wheelchair accessible ground transportation there, that I'd fly in and then I'd just like have to hang out at the airport. And, I tried, I even emailed, people that do sort of disability rights work in the area to ask them for advice about how to get from the airport to the hotel, the whole 9 yards. And it just wasn't happening. So I ended up having to cancel my trip. Now, as some of you might remember, that same year, the snowstorm meant that lots of people had to cancel their trip. It was, and so in this way, it was almost as if the crisis was like an evening thing, right? It wasn't that I was somehow more impacted by the natural disaster, but rather it was sort of that sort of my problem of getting to the conference became sort of a widespread issue for lots and lots of people all of a sudden. And so I'm just trying to think through what the contexts are in which sort of a crisis can actually be helpful to marginalized people, because it sort of makes a problem that was already existent for them everybody's problem in some sense. And if we can sort of think through why it is that sometimes that's the case, but in other times it's clearly not, where a crisis sort of exacerbates disadvantage.
I think a lot of that has to do with the resilience of a world that say takes ableism as a point from which it unfolds, right? So there are some kinds of disasters that universally, I guess, would restrict access to that world for everyone. So COVID-19 is a good example insofar as, the lockdowns required the immediate development of methods of accessibility that folks had been asking for like decades, but were suddenly easy to do now that the world previously occupied was rendered inaccessible. So, I mean, there are ways that these things can level out these kinds of experience, but I would attend to how the responses of the broader institutional structures take place within that world. So to the COVID-19 example, again, is a pretty good one. In responding to these kinds of things, folks had to go through some of the same accommodations request processes that disabled folks have been dealing with forever, and then suddenly realize the problems with those. Or something like in hurricane response, right? When all modes of transportation out of a disaster zone are kind of blocked, one suddenly has an experience of the ways in which mobility is something we take for granted, and so on and so forth. But the question here, the way that you respond to I would respond to this is structures within these worlds predicated on, say, ableism will respond to restore access for able-bodied subjects, right? So in my presentation, one of my slides had advice from FEMA for folks who rely on power to maintain their assistive equipments to call the power company and ask to be placed on a priority list for power restoration, right? Which, you know, putting aside the fact that this assumes you know you're going to lose power in an emergency and so on and so forth, also assumes that said power company will treat your disabling condition as a priority, which probably not. So I would say that from my perspective, given the way that crises and emergencies are experienced differently by virtue of the unique ways that disabled folks transact with the world, I'm not sure that we could actually call particular disasters good in some senses. I would say that they are uniformly disorienting, but even in saying that, I would say they are more disorienting for some folks than others, right?
Yeah, can I pick up on that just a little bit? And I want to make 2 points. The first is that not every member of a socially disadvantaged group is going to have the same experience. And I know that you know this, Joe, but I do know a lot of able-bodied people that did in fact fly down to Savannah, and then they walked the 3 miles across the bridge or whatever to get to the APA hotel. And that's not to say that every able-bodied person was able to do that, but some of them did. And then to connect with Johnathan's comment about sort of the resiliency of ableist structures, I was actually contacted by a friend in another state who works at a university. And as Johnathan mentioned, right, there's a way in the last 18 months that people have now been often given virtual work options that they had been asking for a long time and then get prioritized for other folks. This person works at a university that will give remote working options to everybody with mere request by supervisor, unless the reason why you're asking for a remote work opportunity is related to disability. And so the person who is asking because of disability related issues had been honest on filling out the form, and so then had to go through all this additional work to get the kinds of medical documentation and clearance that had they just said, I want to work from home, they would have been given in 10 minutes. So I think that sort of highlights Johnathan's point about the resiliency of the ableism in these structures that is also part of the answer to your question.
And to add to that, I think in a situation of CSC, when I think about people being told that they're not going to get the ventilator or the ICU bed that they need and that they're going to die instead, I think of that as being an incredibly hard thing to hear for an able-bodied person or a disabled person for that matter. But I think that on a regular basis, there are people with disabilities that experience that every time they go into the hospital. So, in some ways it evens it out in the CSCs, but it's very different. And the concern, obviously, even in a CSC is that, are they as a disabled person going to have, be the one that, is that why they're being cut out of the ICU bed?
Thank you for this this exchange, everyone. I see a question from Eva Kate.
Sorry, again. I thank you for all of your presentations. April, I have a question for you. I thought the Pittsburgh protocol was really, really interesting. There was one thing that, and it was the last thing that you said about people being told that they're not going to get the ventilator or whatever it was that they needed, that they thought would keep them alive. It'd be terribly difficult. When I was thinking about these triage protocols and thinking about the issue of ableism, not ableism, but ageism, one of the things that occurred to me was why don't we ever ask people whether they want to have this intervention when somebody else might want it? Why is that never something that falls into any kind of formal protocol? Because it seems to me that some different people have different ideas about themselves as older, for example, and would rather that a younger person got it, and other people wouldn't at all. But that's something that seems to me to be valuable in this kind of, query.
Yeah, that's a great question. Thank you. And there are actually, so palliative care is considered a very important part of the care of people during the COVID pandemic and during crisis standards of care. And not all hospitals have palliative care or have adequate. I mean, the palliative care physicians and nurses are amongst the people that are feeling this pandemic the most, I think, from the healthcare professional side. And I think they do ask those questions. And ideally, people have advanced directives, although most people don't have advanced directives. But one of the concerns is that physicians will talk people with disabilities into saying that they don't want the care, or people that are elderly saying, yeah, well, I guess I'll give it to somebody else, when that's not really what they want for themselves. And so there's a lot of concern about coercion or bias on the parts of the physicians or the people speaking to them to influence them in ways that would undermine their autonomy.
Yeah. But it's too bad that we can't just say, it's okay. Give it to someone else and just have that be part of what we want to say.
Yeah.
Well, while we're waiting for another question to drop in the chat or for someone to raise their hand, I just want to add a kind of comment that maybe functions as a summary of some of the things I heard today. And one of them is that the ideal of equality so often can get in the way of equity. The ideal that we should all be treated the same gets in the way of understanding the ways in which people should be treated differentially. Some people need more care, more time for care. Reparations should be provided for past and ongoing historical injustices, etc. And it seems to me that one of the very powerful overarching points of the talks today is that as a society, not simply with respect to America, but as now an inextricably linked global community with regards to the impacts of climate change, we have to think more carefully about the ways in which we take seriously the idea that everyone has equal rights, merely by virtue of being human, and any number of other beings beyond human animals also deserve any number of rights, ecosystems as well, et cetera, et cetera. You get my point, but that the move towards an equalization of things has actually led to all sorts of injustices that COVID made so painfully apparent. And we need a more equity-based approach, one both for the human, whatever we qualify as the human, and all sorts of non-humans as well.
I have to go pick up my daughter, but I just wanted to say thank you so much to everyone. This was wonderful, and I look forward to seeing later versions of these papers and presentations. Have a great night, everyone.
So we have successfully hit 10 minutes prior to 5 p.m. We have time for some more questions if someone wants to jump in, but also if you are like me, you are very tired. And it would be perfectly fine to end things right now. I have learned so much today. I want to thank again so much our speakers for fantastic, provocative, engaging, and expansive talks that I think give us, and by us, I really mean the global community here, lots to think about in terms of disability rights, disability justice, and also what it would mean to actually live in a world where everyone is treated more justly and equitably. And now, after setting things up in that way, I feel like I have to end it because that was the, yeah, okay. My apologies there rhetorically. All right, we'll call it an evening. Everyone needs to go have their wine or beer or water, whatever they prefer at this point on a Friday night. Also, Schnurp, yes, I actually fed him real quickly when I jumped off screen because I think he might have revolted if I had not. Thank you all so much for being here. To our YouTube audience in posterity, thank you for watching. Please reach out to us if you have any questions. Love you all. Have a wonderful evening.